Thank you very much for that, Angela, and hope everybody had a nice break over lunch. I'll try and keep you all awake with some scary stories. So I'm going to talk about the emergence of these two viruses in Australia in recent years, including the environmental factors that have driven disease transmission, and how our knowledge about some of these environmental factors have been used to produce risk maps to help us be more prepared for future outbreaks, and then also a bit about vaccination strategies. So that's just an outline of the talk, and we'll move right into it. Okay, so there are many similarities between these two viruses. They're both flaviviruses. As you can see on the diagram there, they're phylogenetically very related, and also closely related to Kunjun and West Nile viruses. They're all mosquito-borne and all have strong environmental drivers of transmission. They're relatively rare in Australia, but they can cause very serious illness, including death, and there are many surveillance and diagnostic challenges for these viruses. So many of you would have seen this diagram. As you can see, complex transmission cycles that involve mosquitoes, water birds, and pigs act as amplifying hosts. So this is for JE, and then humans and horses are dead-end hosts. So this virus is not a new virus. It's been circulating around in Asia for a very, very long time, and it's the most common cause of viral encephalitis in that region. More than 100,000 cases per year and 25,000 deaths. So most human infections are asymptomatic, so there are even more infections than those numbers there. And severe disease occurs in less than 1% of people. So the number of cases that we see that get reported, there are many more that are either asymptomatic or just undiagnosed. And case fatality can be up to 20-30%. And of those who survive, 30 to 50%, something like that, develop some sort of long-term neurological complication. So, it's a serious, nasty illness. And very effective vaccines available for JE, but no specific treatment. So in Australia before 2021, we had a handful of cases in the 1990s up in the Torres Strait Islands and Cape York. But really, it was a very uncommon event. And then from 2012 to 2020, we had 14 cases reported to NNDSS, and all of them were acquired overseas. Some of these people died, and the last case who died was in November 2019 in a male who had been to Bali for multiple and prolonged trips. But like I said, likely to have been many either asymptomatic or undiagnosed cases that were mild. So from 2021, everything changed for JE in Australia. There was local transmission in southern parts of Australia that had never been detected in the past. So I started with a case in the Tiwi Islands in February 2021, then detection of JE in stillborn piglets, and then about 45 cases across 5 jurisdictions right across southern Australia, and a lot of them ended up in hospital, 7 deaths, 17% case fatality rate, and huge economic loss as well for the agricultural industry. So in March 2022, Australia declared a communicable disease incident of national significance for Japanese encephalitis. So this was a major event for us. So since then, we have had more human cases. We've also had detections in mosquitoes and pigs. And there have been a number of different seroprevalence studies done in different groups in New South Wales and Victoria. You can see there's quite a bit of variation in seroprevalence in these studies, but they targeted different populations. So, sampling design was different. So we wouldn't really be able to compare those results directly. But the ultimate message from all of this is that there is substantial, silent, widespread and endemic transmission in Australia, including southern Australia. So this is a big problem for us. Then Murray Valley encephalitis is not new to Australia. We've known about it for many decades. And the clinical features do overlap with JE and other causes of viral encephalitis. With this one, we've had intermittent outbreaks with long periods of relatively quiet time in between, an average of just a few cases per year. So I've listed some large historical outbreaks there. The largest one was in 1974 with 58 cases and case fatality of 20%. So you can see on the graph there in more recent years, 2011, there were 11 cases. That was the biggest outbreak up till that time in that decade or so. And then 2022, 2023 summer, we had the largest outbreak since 1974, 27 confirmed, probable or suspected cases, reported across 6 jurisdictions, so everywhere except for Tasmania and ACT. And the age range of these cases were from 6 weeks of age to 83 years, so really across the whole spectrum of age, and highest incident in the Northern Territory. And the last summer, we also saw a few cases in WA. There was some post-outbreak serology done in Victoria in 2023. 2% of people were positive. So this is a bit of a different story to JE in that it has been around in Australia for many decades, but this large recent outbreak was also a concern. So there are lots of clinical and diagnostic challenges for these viruses. There are overlapping symptoms and signs, not just with these two, but other causes of viral encephalitis. And because of the non-specific clinical presentation in the early stages, sometimes they will get missed, diagnosis will be delayed. And if the case presents to an area that, where the doctors did not know that there was JE transmission, they probably wouldn't think about it at all, so delayed diagnosis again. And serology is the mainstay of diagnosis, but there are lots of challenges related to cross-reactivity between the flaviviruses, so JE, MVE, Kunjun, but also other flaviviruses that either don't circulate in Australia or are extremely rare, like dengue. So people who have had previous infection with flaviviruses or previous vaccination for flaviviruses, like for yellow fever or for JE or for dengue, the dengue vaccine will be available hopefully by September or so this year, the new dengue vaccine. It's going to become even more complex to interpret serological results when we have multiple viruses circulating and then people who've been vaccinated and people who've been infected. And with PCR, because of the later presentations, a lot of people might actually be PCR negative by the time they develop encephalitis. So that's also a challenge. And PRNTs are not that easy to get access to. They take time to do. MRI findings can be useful, but we really need serology to confirm the diagnosis. And there's no disease-specific treatment for these two viruses. So I just want to talk a bit more now about the environmental drivers of these viruses. And it's not just these two. We're talking about these two because these have recently emerged in Australia. But globally, dengue, for example, the numbers have really just skyrocketed around the world, including in our close neighbours in the Asia-Pacific and in the Americas. So they're driven by many different things, including changes in climate, rainfall, particularly flooding. So a lot of the events in Australia have been related to major floods. Also the way that we change our environment, so changes in land use, water management, and because of the transmission of these diseases, which involve mosquitoes, water birds, pigs, and animals, the population distribution and density of mosquitoes and animals also make a difference. And so it's a complex situation, and these drivers are dynamic, meaning that they can change quickly. They're not the same year by year. They're different in different seasons. So that's why we see, different numbers between different seasons and over time. So since the 2021-2022 outbreak in Australia, various groups have used this information to generate risk maps for Japanese encephalitis to see if we can predict which areas are at higher risk for JE transmission. And so I don't have time to talk about all of these models, but there's some references listed there for people who are interested in this. But just very broadly speaking, they've used a wide range of modelling strategies. So things based on vector suitability, so whether mosquitoes are likely to be in that location, landscape epidemiology related to land use, etc., proximity-based exposure, so people who are closer to piggeries, and using geographic information systems to bring all these risk surfaces together, and looking at spillover models, which are ecological niche models, which I'll show you an example later on. And so the inputs for these models include mosquitoes, water birds, pigs, various environmental factors, things to do with humans like population density, proximity to piggeries, and surveillance data. So, as they say, all models are wrong, but some are useful, and there are some common limitations of all of these models. So there are major data gaps related to mosquito populations, birds, pigs, very complex transmission cycles, so trying to determine which of the drivers are more important for transmission than others is challenging. The temporal components, so every season is different, so we can't, easily predict when an outbreak might happen because that depends on major climatic events, particularly floods. And also there are lots of uncertainties about assumptions in these models, so the contact rates between mosquitoes, animals, humans, and one thing that's not incorporated in these models is human behaviour, including vaccination. And it's difficult to validate these models because we've had so few cases, human cases of these diseases. So normally you would use cases to see whether your model is working or not. However, despite those limitations, there are some common conclusions of these models. One of them is that environmental suitability for JE transmission is much more widespread than where we've seen cases and outbreaks. So there are lots more areas where no cases have yet been reported, but it's possible for transmission to happen. And in the highest risk areas align with where there are wetlands, water birds, pigs, especially around the Murray-Darling Basin. And some of these models have predicted the size of the population that would be at risk under ideal transmission situations. And these have ranged from hundreds of thousands to 2 million. And these maps are useful for things like risk assessment, prioritising surveillance and interventions, and potentially for scenario analysis based on different climate predictions. But they are really not useful for accurately predicting the timing or the location of the next cases or the next outbreak. So I think we need to understand how to use these maps and what their limitations are. But one of the things that is quite common between these studies is that further outbreaks are highly likely, especially when there are strong environmental drivers. So we're very likely to see more of what we have seen so far. So I'm just going to go a little bit more deeply into one of these models. This is the latest one that's been published. It was done by a postdoc in my group, Eloise Skinner, who is an ecologist. And they think about things quite differently to clinicians and basic scientists. So essentially, these are spillover events into humans. And spillover is a multi-step ecological process. So it's a sort of Swiss cheese model. You need all those things to align for outbreaks to happen. And so using this conceptual framework of layers of mosquitoes, birds, pigs, people, the question is which areas in Australia have the best or the worst mosquito and host communities for JEV spillover to occur. And for those who are interested in this sort of modelling, there's the paper has just very recently been published. You can have a look in more detail there. But essentially, it's an spatial intersection of layers of information. So it took a bit of work to actually put these layers together. But the distribution of birds, feral pigs, and we have a lot of feral pigs in Australia, domestic pigs, as well as the main vector mosquitoes, to generate a risk map, which is the bigger map on the right there. And the top map in the top right corner shows the Murray River Basin, New South Wales, Victoria. And as you can see, there are lots of areas there where it's highly suitable for JE transmission because of the overlap of these things. And, we certainly have seen cases there. So I'll just go back one. So looking at maps like this, there are lots of areas in Australia, as you all know, that's completely uninhabited. So even if there's a high transmission potential, there are no humans there, I guess, it's less of an issue. So what you can do is overlay population density maps to see which LGAs are likely to have higher numbers of people who are at risk or high proportion of people who are at risk. So those are just the general concepts of these risk maps. And ultimately, when we change ecosystems, we change disease ecology, and we're continuing to change ecosystems. And so this is going to be a constantly evolving situation. So moving on to JE vaccines now. These two vaccines, JEV and JESPECT, have been around for a long time. So I won't go into them in any great detail, and all of this information is in the Australian Immunisation Handbook. But we have two very effective vaccines in Australia, and they're both very safe. So this is data from SmartVax in almost 3,000 Australians, showing that both vaccines are very safe. So the current recommendations for JE in Australia is that for people in a JE risk region who may be bitten by mosquitoes, I'm not sure about that last bit because anyone can be bitten by mosquitoes, especially me, and people who work or live in the Torres Strait Islands, laboratory workers who might be exposed to these viruses, and travellers to endemic areas. So until the recent outbreak in 2022, that top recommendation was not there. The bottom three have been there for a long time, but not the top one. So let's look at the top one in a little bit more detail. So the risk areas within each state and territory is determined by the health departments. And I won't list them all there. They're in the websites and they do change a bit over time. But also the people who where vaccination is recommended include people who spend a lot of time outdoors, either for recreational activities or for work, people who are homeless, those who live close to piggeries, people with high-risk occupations, and those involved in disaster and flood response. And so going back to a travel medicine perspective, so before 2022, JE really was a travel vaccine in Australia. And one of the major barriers for travellers to have this vaccine was cost. And so we did a study in Dr. Depp, the Travel Doctor Clinic in Brisbane, on 50 adults. And we gave them 0.1 mil of JEV intradermally, so that's 1/5 of the dose of the usual subcutaneous dose, so which usually 0.5 mil subcut. And we show that by day 28, 100% of people were seropositive. So this was done with travellers in mind, and just as we published this, the Australian outbreak happened. And so we shared our results with ATAGI, and some of you might remember at that time there was a shortage of JE vaccines, also very expensive, and so there was a ATAGI recommendation that intradermal JE vaccine can be used as a dose-sparing strategy in outbreak situations. And so that study that was done in Deb's clinic was just on 50 adults. It was not a direct head-to-head trial between intradermal and subcut. So these are some preliminary results of a field trial in New South Wales, led by Nick Wood from NCS and together with New South Wales Health. So this is some direct comparison of intradermal and subcut, and this is from age 5 years, 200 and something people. And as you can see there, seroconversion at 1 month and 6 months is really great for intradermal. So if we get another outbreak, this is certainly something to consider. Another thing that people have been concerned about is whether intradermal vaccination lasts as long as JE vaccination, so long-term immunogenicity. And so going back to those 50 people from Dr. Depp's clinic now, we followed them between 1.5 to 2 years later, and 93.5% of them were still seropositive at that time. So we will continue to follow them up, but we can at least say that, they'll be protected for at least a year or two. So in an outbreak situation, or also for travellers who are just going on a short trip, it does make the vaccine much more affordable. So this is JEV again, the intradermal live vaccine. So for those of us working in travel medicine, back in 2022, we got a lot of questions from our international colleagues. Do we need to vaccinate our travellers coming to Australia for JE? So Sarah McGuinness and I wrote this paper, and we actually mapped out the LGAs across Australia where vaccination was recommended at that time. So maps like this are very useful, I think, not only for our international travellers, but also for domestic travellers going to different states who might not be very familiar with, lists of LGAs. And so this is from March 2023. It does need to be updated, perhaps something for the new Australian CDC to take care of. And so just a few take-home messages. These are rare but serious diseases. Transmission is strongly driven by environment and dynamic. And the recent emergence in Australia shows that, really the epidemiology and risk is changing rapidly. And these are really just sentinels of broader environmental change. And we're likely to see more outbreaks unless there's anything, dramatic that happens with environmental management. So we need to move with these changes in terms of surveillance, diagnostics, response, and also our vaccination strategies. So I'll leave it there. Thanks very much.